Hey everyone, and welcome to the AgeTech Connect podcast, where we dive deep with innovators, entrepreneurs, and industry leaders to figure out how technology can make the world a better place for older adults and those that care for them. Today, I'm having a conversation with Pat Tarnowski from OneStep. OneStep uses the power and accessibility of the smartphone without any extra wearables, sensors, or devices to unlock the story behind everyday movement and generate meaningful clinical insights. In today's episode, Pat and I will be talking all about human movement as a metric for health and how accessible, passive movement capture solutions like OneStep are changing the way we provide care for older adults. So, Pat, love to have you on the show. Welcome back. I know you and I have had quite a few conversations, one-on-one. We've known each other for a little while, but for all the people out there that don't know you, or don't know anything about OneStep, can you tell us a bit about who you are and your background and how you got into what you're doing?
Yeah, absolutely. Dan, great to see you again. Yeah, it's been really fun to get to know each other over the last several years, whether in person at physical therapy conferences or we did take one of our podcasts a year or two ago.
Background for the viewers: we're both physical therapy nerds, so if we get a little bit too nerded out, you just got to bear with us.
That's right. That's right. Yeah, because when you put two PTs together in a room, you tend to go deep into the weeds on PT. Yeah. So a little my background, and then really excited that we could transition over to talking about what we're doing at One Step and the
Mhm.
impact we're having in the senior population as well as many others. But like we said, I'm a physical therapist, practiced for a long time. Most of my focus was on foot and ankle and lower extremity biomechanics. Loved what we did. Had a very thriving practice, had an opportunity to spend a lot of time teaching, whether they were continuing education seminars or a few academic appointments, adjunct faculty. And after about 10 years, realized that I love what we're doing, but I really like the business of our business.
Mhm.
And so made a transition from day-to-day clinical work into the medical device world. And at the same time did an MBA. And so, gosh, I think it was 7 years in the medical device world and got to touch every part of that space, whether it
Yeah.
was product development or marketing or working with our sales team or, M&A activity, and saw how important design and form factors are for the provider, because there's an awful lot of great ideas that if they don't really have the provider in mind and of course the patient in mind, then you tend not to have good success. So it was a tremendous opportunity. And then moved from there to be able to lead the rehab service line for a very large health system here in Minnesota. So all of the PTOT speech, physiatry, nursing research and foundation for, gosh, across 11 hospitals and I think 40-ish outpatient locations. So really now got to see, how do the health systems think? How do administrators there work? What are the pain points that they're having? And they tend to, we can maybe get into this conversation. Those pain points tend to be a little different than the pain points we tend to talk about as clinicians. So we really grew that up, and that service line grew nicely with really heavy emphasis on cost and quality, as well as patient engagement and team engagement. And then took a bit of a shift to spend time in the venture world,
Mhm.
spinning up a portfolio company that focused on musculoskeletal health. It was physical therapy, chiropractic combined, and this is several years ago when sometimes those two professions did a lot of this.
Yeah.
And when we put them together in the same room, we found there was a lot more common ground than different ground. And when you put them together into a common treatment path, the outcomes were off the charts positive.
Mhm.
Patient experience was great, cost was low, and outcomes were terrific. So we got that up and running, and then I had the opportunity to join a large health plan, to sort of round out like the healthcare experience. Now let's
Yeah.
understand how health plans think. Health plans fancy for the payers. So wore lots of leadership hats there, but one of them, maybe kind of most relevant to the work we're doing here at One Step, was I led a team that oversaw a portfolio of digital health products.
Mhm.
So we got, I think there may be 25, 28 products in this portfolio. So these were things that we would use to engage with our members. So again, the language starts to change a bit. The health plans say members, as providers, we say patients. And so we got to see what works, what delivers true clinical value, what delivers true economic value, and ultimately what engages the member, the patient, however you define the end user. And then with all of that as background, I went off on my own, had a consulting practice, and got very busy helping founders and CEOs of younger companies understand how to kind of navigate this crazy US-based healthcare ecosystem. So that's a bit of my background. And then one of my customers, as my consulting practice, was OneStep. We go deeper into what OneStep does in a moment. But after spending about 6 months together doing very deep customer discovery work about the amazing technology and service at OneStep, it was very clear. We've got entrepreneurs and founders that are listening as part of the audience. The customer discovery was so important because what we were able to learn was what really keeps these potential customers up at night. What are their pain points? What are their ecosystem? How do they make decisions? How do they budget? What's in front of them? And so after doing, I think, about 100 very deep customer discovery conversations, we had literally 99 of those conversations. There was one PT that was not a super supportive, but betting 99 out of 100 was great.
I'll
So
take
the
99%.
yeah, I'll take 99 very
Yeah.
happily. So what we heard was, hey, you at OneStep, you can solve problems. That was verbatim. You can solve a lot of my problems. In fact, you don't even know which problems you could solve. Could I help you understand that? So with all of that, we clearly had found some sort of product market fit. And that was the impetus when the One Step team said, hey, would you like to join us and lead the entry in the United States commercially? I said, yeah, absolutely. So long answer
Yeah.
for the little me and how I got here.
Well, could you explore what were some of those big gaps that you were identifying? So you said you've come all the way up from clinician all over the healthcare system, and you said one of the big problems you saw was that product market fit. So what were those gaps you were seeing where the solutions that were coming out weren't quite meeting the need of clinicians, patients, members, what have you?
Yeah, it's such an important question, which sounds really elementary to
Yeah.
address. There's a concept of founder bias.
Hmm.
And we saw this back in the medical device days. So I'll pick on academics for a moment because I know you're you're
Yeah.
just about through the throes of your PhD, right?
Yes.
So we have brilliant academicians and brilliant researchers who say, I want this product to be able to do 14 things.
Yeah.
And then would bring a product like that to market. And what the customer really is looking for is simplicity.
Mm.
And they're looking for, I have a problem. Did you solve it? And, we used to say things like, all the customer wants is on, off, up, down.
Mm.
Make this super easy for me. So all of the biases that we tend to have as a founder, as an inventor, my product can do these 14 things is a bias of the founder. What the customer may want is something very different. So part of this idea of discovery, Daniel, is it's hard. It's hard work because we need to say, so if we're role playing that discovery conversation today, Daniel, tell me about, or what are the financial challenges you're dealing with, or what are the operational challenges you're dealing with? And I don't get to talk about my product to you. I
Mm.
get to listen to you. And that's really hard because if you're a founder and you want to get something in market, you want to start generating revenue, I want to use this as an opportunity to start pitching.
Mhm.
But the challenge is to really say, help me understand you. How do you connect to this person? If you were to purchase something, what must be in place?
Mhm.
What's important to you? What are the must haves? What has gone bad for you when you've tried to do something? That's how you start doing discovery. And then you come back. And when you have those discovery conversations, have a few people there.
Mhm.
So one person is the interviewer, the other is really the scribe and really understanding. Then you debrief and say, what did we learn? So you're testing a hypothesis. We believe, Daniel, that this is a problem that you have. What did we get right? What did we get wrong?
Mm.
That's how you start to uncover the gaps. And we certainly have learned that with OneStep, and I've advised several other companies prior to OneStep. We've certainly learned that here. Like, okay, we can do this and this and this, but what do you really care about?
Yeah.
Or the one thing, or maybe even the one problem.
Yeah.
What is it they're really wrestling with? Now, where that gets sometimes challenging is there's only so much bandwidth that a customer has.
Yeah.
When we at One Step are talking with senior living owners or operators, it's very clear. They've said, I can probably tackle, I'm making up a number, 3 new things this year.
Mhm.
So, how many one things can we have versus here's a solution that can solve several problems for me? It still needs to be simple, but how does it transcend my organization? versus it's the one niche that does this that doesn't connect to other things. And that starts to create complexity, it creates cost, it creates administrative burden, and it creates disengagement from the frontline providers that are they're the
Yeah.
people that we're all counting on to use these phenomenally cool technologies.
Yeah, and I love that you pointed out kind of the perspective a lot of clinicians and scientists take, where it's like we're just question oriented. We like to be innovators. We want something to work, and we want to solve all the problems that we can. So we kind of think, oh, we're going to create the biggest possible solution that we can, and if you do it just right, it's going to fix, A, B, C, D, E, F, G, right? It's going to fix everything. But in reality, I mean, yeah, most people want when you really get down to it and having a customer discovery. I mean, you see that people just have one nagging problem that gets at them. And if you can get a solution that hits that problem on the head without creating a lot of demand from the user, that seems to be the magic recipe.
Yeah, I think there's a lot of truth to that. And certainly there are layers to what you just
Hmm.
described, but that's really it. And I had the benefit of being part of the National Science Foundation's I-Core program.
Hmm.
Yeah, so they are all about customer discovery. You got to get out of the building and you got to go talk to people. In fact, one of the books that we used in there, or the book, I sorry, I don't remember the author, is called Talking to Humans.
Mm.
So how do you actually get out of your building, go talk to somebody, understand what they're up to, and never talk about your product?
Hmm. I want to read that book. That sounds very interesting.
Yeah,
I got to remind me to follow up with you on that. But
yeah, for sure.
so throughout this customer discovery process, you talk about finding that one big problem. What did you guys find with One Step? What was the big thing that you were addressing?
Yeah. So maybe let me just back up from just a little context on what we're doing at One Step first.
Yeah.
Here, we'll geek out just for a moment as clinicians. For those of you that are listening that are non-clinicians, just come on back in 30 seconds. So one of the things that's very well established in scientific literature is the importance of mobility as a leading
Hmm.
indicator of health. So
Yes.
we've talked about gait and gait speed as the sixth vital sign for many, many years. And just kind of statistically, if somebody's gait speed drops from even below zero point 0.8 meters per second down to something as small as zero point 0.7 meters per second, their risk of falling goes up about somewhere around 8 to 10%.
Hmm.
Their risk of cardiometabolic disease goes up. Their risk of cognitive decline, it's an early indicator of cognitive decline. Their
Hmm.
mortality risk goes up 12%. And for all of the administrators that are in the health system or the risk bearing world today, your risk of readmission goes up 10%. And
Hmm.
we should let that hang for just a minute because that is one of the key drivers of healthcare cost and quality today and what everybody is trying to focus on. How do we reduce those readmissions? Well,
Hmm.
and so we do things like measure blood pressures and we make phone calls. Daniel, you were discharged from the hospital. How you doing? Do you have a ride to your doctor? You have your medications? Do you have food? All those things are important. But what if we said, Daniel, are you moving? What's the quality of your movement? So the challenge there has been you and I could measure a patient in our clinic
Yeah.
or in our skilled nursing facility or in our hospital. But when you leave, I have no idea how you're actually functioning.
Hmm.
So that's the problem we've solved for at One Step by turning any smartphone into a clinically validated gait and mobility intelligence platform.
Hmm.
So simply by putting a phone in a pocket and walking, zero hardware, zero cameras, zero expense other than the expense of licensing the software, we complete a full analysis of mobility with as few as 10 steps, and we do it passively. So anytime you, as the patient, happen to be moving with your phone, we will capture clinically validated data.
Yes.
And then we translate that back into insights to the provider team that says, hey, Daniel's showing a decline. Daniel has not been moving. When he left the hospital, his mobility was here, and now it's been 3 days and it's here.
Hmm.
We should reach out now before the bad event happens. So the ability to now identify a declining mobility signal as early as 14 days in advance of a fall or a readmission is a game changer.
Hmm.
So we're deployed in 500 seat plus senior living communities today, and our customers are reporting their falls have come down 23 to 25%.
That's amazing.
Those aren't just big
Yeah.
numbers that are, with all the
That's
quality
huge.
and the cost impact. Those are real humans,
Yeah.
that
And
are
falls can be
experiencing.
deadly.
Yeah, they are. And they're a leading cause of readmission and emergency department use.
Mhm.
So when we come back, it was a long answer. We got a little geeked out again. A
Yeah.
long answer for what's the problem we're solving is the problem that providers, owners, and operators in senior living hospitals have had is a lack of insight into the mobility vital sign.
Hmm.
And we don't have to prove the science again. The science is well established. You know, as a clinician, there are truly thousands of articles about the importance of mobility as a vital sign and the correlation to nearly every diagnostic category,
Hmm.
but we've been unable to measure it in a natural environment at a clinical level. We certainly can measure things. Our watches give us really good information, but they're not clinical.
Yeah.
We've now solved for the clinical gap and we bring that back. So that's the gap that we heard back to discovery was, especially in senior living, it's not an if, it's a when related to falls. And it's
Mhm.
not even a when, it's a how many. And all of the downstream effect. Of course, there's impact on the human that falls and their family. There's impact on the workforce because that takes time. Decisions about going to the hospital. There's impact on the system because readmissions are very expensive. There's impact on the psychosocial elements because it's likely if you fall and you're in assisted living, you're not going back to that place of living. You're going to a nursing home for the next level of care. So there are so many adverse downstream effects. What if we can start swimming upstream?
Mhm.
And that's the problem. We heard as we did deep customer discovery, falls, 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 falls.
Mhm.
How do we look at that? And mobility, it would be great if we understood how people are moving, but we can't do it today. Those are the kinds of learnings that we had and where we got really excited about being able to bring a system like this to market.
Because you pointed out, I mean, this has been a very important area of research for quite some time. I mean, we know how mobility relates to fall risk. We know how to utilize mobility interventions to reduce fall risk and reduce the readmissions and improve clinical outcomes and everything that you brought up. But that story's been relatively hidden, right? Because we have to do that in the clinical setting. We have to have a
Mhm.
professional do it, maybe sometimes even in an advanced gate lab. You guys use a tagline, "Every step tells a story," and
Mhm.
I really like that one, but historically, that story's been hidden. So what you were seeing is, like, people were developing the awareness that we really need to see how these people are moving, but you just don't have the access to do it unless I send them out to the clinic or out to the gate lab. Can you tell me a little bit more about what kind of problems that caused when movement and gait analysis were hidden behind closed doors and nobody really knew the story that a person's steps was taking?
You're spot on. We've known it a long time,
Mhm.
but this is also the world that we as physical therapists, the movement specialists, we've understood. But oftentimes if we think of like a health system or a hospital, there are stacks of orders to have PT and OT come evaluate Mrs. Jones to make sure she's safe to go home. And frankly, there are more orders than there are therapists to see those patients. So when we get a little bit backed up on that, it impacts length of stay. And if length of stay goes up 2 hours, there's a meaningful expense to the hospital in a DRG model, right? So the social workers, discharge planners, physicians have all recognized the importance of mobility, but they've done it kind of through the lens of discharge.
Mm.
When you look at senior living operators, we know that it's important for people to be up and moving, but that tends to be something that happens down in the fitness center or down in the therapy team. Or
Yeah.
and maybe the restorative team is able to have somebody up and walking a bit. The gap has been one, how do you quantify what's really happening? So in a skilled nursing facility, imagine the power of having when the nursing team is rounding, so they're going from room to room and they're doing their regular vitals, to be able to say, all right, Mrs. Jones, let's stand up. I'm going to put my facility phone that I'm already probably doing my documentation on.
Mhm.
I'm just going to drop it in your pocket. Let's take 10 steps. Now I've got objective data to be able to say my fall risk is getting worse, it's getting better. And even to say it appears as though based on this and this that Mrs. Jones is more likely to fall to the left. So let's set up the environment for that, based on sway. And then to be able to say, now what's happening when Mrs. Jones is outside of her room?
Mhm.
We have eyes, we've got beautiful cameras, we have beautiful ambient listening systems that are such integral parts of safety and care. But what happens when she's out of the room?
Hmm.
So think of assisted living, independent living, where, the seniors are the fastest growing adopters of mobile technology. We know that. Imagine the power of being able to say, wow, when you're moving about in your natural environment, these are the changes we've noticed. Your speed has declined, your asymmetries increased, whatever those kind of leading indicators may be.
Hmm.
We should now proactively intervene. So the problem has been not a really understanding objectively how somebody is moving, and then how they're moving when we don't have eyes on them.
Yeah.
And it's a big problem. It took a little time. We've said we're doing a little bit of category creation,
Hmm.
to say it's now actually possible to measure this way. And it's been very fun to see the market begin to understand this and say, this makes a ton of sense. Yes, let's bring this in because it's the right thing for patients. It's going to drive our liability claims lower. It's going to drive our quality scores higher. And it's for those that are participating in a value-based payment model, it's only going to enhance the performance.
Yeah. Can you tell me a bit about what One Step, how does it do what you're describing? So you talked about I could take my phone, it's got One Step on it, and I'm gonna put it in the patient's pocket and just 10 steps, and I can get all these, amazing, really clinically relevant metrics. How did that solution come about? How does that work? What does that implementation look like?
Yeah. So there are three brilliant co-founders who all come out of the tech world. One is a physicist who worked on sensors. One is a cybersecurity and computer science genius. The other is machine learning and data science. And they said, we really want to do something for good.
Hmm.
There has been a mission from day one, and really understanding the importance of gait, where we started the conversation as an important indicator of health. How do we make measuring gait as simple as stepping on a scale or as simple as doing a blood test?
Mm.
So you have to look at what vehicles can you use.
Yeah.
So, your trivia for the day, more people in the world have access to this than have access to indoor plumbing.
That's that's a good fun fact. I'll
Yeah.
bring that up at
And
parties.
yeah, there you go.
Yeah.
Yes. Yeah. Now the audience knows why PTs tend to geek out, right?
Yeah.
That's the sort of party trivia. So when you look at the most ubiquitous device in the world, it's right there. So the ability to now use motion sensors, and as probably most folks know, nearly every phone out there today has very sophisticated motion sensors in them.
Mhm.
They're always on. And we see that when we're using our maps. Anytime you turn your phone, you see how it's moving with you. So the thesis was, what if we could turn that movement data into a pattern that replicates the gait cycle?
Hmm.
And so by having the phone near the thigh, we can capture data on a crossbody purse from wearables and all that, but we'll just say in the ideal setting,
Yeah.
it's near the thigh, and we're able to get motion across multiple planes. And really the IP is translating all of that raw data, the
Mhm.
IMU data, into standardized gait measures. And that's where one of the things I've appreciated about this team is nothing went to market until it was clinically validated.
Yeah.
So the team has published, I think we're now at 15 peer-reviewed papers.
Oh, wow.
First, it looks at our ability to capture data compared to, say, the gold standard gate labs.
Mhm.
And there's no question about the validity of what we do. Then it gets exciting to say, now, how do we apply this to specific populations? So our team just pushed out one of our latest papers around hip and knee replacements.
Hmm.
So we've got, gosh, these numbers will be directionally correct, but probably nearly 70,000 patients with hip and knee replacements that we have measured and monitored with the platform.
Wow.
So we now know what recovery should look like. And it's very interesting. Again, sorry, again, we'll geek out here for a moment. We know that if you have a patient in your clinic, Daniel, they tend to move differently when they come across the parking lot
Yeah.
versus how they move when they're with you in clinic.
Mhm.
The same happens in recovery trajectories with these patients. So we know actively. So if I have One Step on my phone, and again, we're an FDA registered app, push
Yeah.
go, record a 10-step walk, I know what recovery looks like. And at about 6 or 7 weeks post total knee replacement is when most patients will start to see that they've achieved their pre surgical gait speed baseline. But what happens in the background, the passive data capture, it actually gets delayed until more like weeks 12, 13.
Mm,
So when you know you're being observed, you behave differently.
yeah.
When you're functioning much more in your natural environment is when you see a very different recovery trajectory. So this data, we're getting, I think we're nearly 3 million gait cycles a day that are coming into the database. So we're probably closing in on about 40 billion gait cycles in the database. So there's a lot of power in that data. We are now establishing what population norms look like.
Yeah.
So all of this data just with coming through the phone and using again the most popular device in the world
Mhm.
starts to create almost an unlimited potential of applications.
And I want to get into, the passive versus active capture and the use of this big database with how you guys can really kind of drive the clinical narrative because you guys have a
Mhm.
really unique position that, goes beyond established science labs at this point, because you're collecting so much data and you're collecting so much of it in the real world. But before we get too much into that approach, I want to kind of go back to so gate's such an important metric, and it's such an important metric for so many individuals, post surgical, as they age, people in senior care facilities. But who actually uses One Step in house? You've given a few examples. So, somebody in a hospital might use it post surgically. Is it used by the individual? Do they download it and use that data themselves? Is it used by care teams? And I know you guys have a lot of different areas in which you apply. So
Mhm.
if you could give me some of the main buckets that One Step has found a lot of success in.
Yeah, and I think you're asking two really important questions. First, who's the buyer?
Mhm.
And then the click down, what's the workflow?
Yeah.
And again, if you don't have both of those, it makes commercial success
Yeah.
much more challenging. So we bucket our work into say 5 key buckets.
Mhm.
The first is senior living communities, whether it's skilled nursing, assisted living, independent living, care in the home, private pay, or formal home care. And I'll come back to a bit of the workflow in just a moment. Okay, maybe just kind of do the buckets. A second is medical device partners.
Mhm.
So we have several very large global medical device companies who care about gait and care
Yeah.
about mobility. And so we have an SDK kit where now these companies have picked up our algorithms and we live inside their app. We power their mobility intelligence layer. So we have some very large orthopedic implant companies that are using us not only to get longitudinal data about the performance of their device, which is great for R&D, great for quality outcomes, gives surgeons the ability to bill for remote monitoring services, but that data starts to help inform surgical intelligence suites as well. We think of all the robotic work. So, oh, based on these X-rays, these CT scans, these surgical pre-surgical assumptions, now here's the longitudinal impact of recovery that starts to inform algorithms. Lots of work in implants, braces, robotics, prosthetics, neurorehabilitation, neurostimulation or modulation for pain are using our data to help them really show the impact of their interventions, which is super important for them for sales
Yeah.
conversions and super important for them for payers and quality and value-based care models. We do a lot of work with large health systems. We have many, many large health systems that are using us in a large breadth of applications, hip and knee replacements, multiple sclerosis, Parkinson's disease, helping understand the impact of chemotherapy on mobility and frailty. We've got one group very interested in bringing us in to help power their COPD program. So what's happening when the patient is not there? And then it's been very exciting. We've now been asked to come in and power accountable care organizations and HMOs for all the same reasons. Yeah, I met with the president of one large HMO who said, Pat, if you can help keep one of my members from going to the hospital, this is an absolute no-brainer. So again, it's the mobility as a vital sign. And then a last bucket for us is really around large technology. So we have several large consumer technology companies that have said this would also be a very interesting biosensor and signal for us. So those are kind of our buckets. And if we go in a little bit deeper, let's just focus on maybe the workflow for senior living. So I
Yeah.
mentioned a bit of like unskilled nursing. Most of the residents of skilled nursing are probably, our data shows that maybe, 20, 30% of them have their own smartphone.
Mhm.
So, in that case, in skilled nursing, those providers are using One Step, as I mentioned, to do rounds, to get baseline measures. As residents are in the fitness center, that team is using One Step to capture data. So it's not only gait data, but also important measures like a timed up and go, a sit to stand, dual task walking, functional reach, balance and sway with Berg and Tonetti. All of these things can be done in the OneStep app. And when we think of the problems to solve, there are huge workforce issues or staffing issues.
Yeah.
None of what I just described requires a licensed provider to do. So anybody can use this platform.
Mm.
So a non-licensed member of a team can get objective data. When we look at like the assisted and independent living, the story changes just a little bit there because senior living, they're being generally paid on a per diem basis.
Yeah.
And our partners are now using our data to go back to their managed care partners and say, don't kick Mrs. Jones out yet. She's still at a very high risk of falling. Give us an additional 5 days, 7 days. We will show you objectively how the fall risk has declined, and then she's safe to go home because none of us want to have the fall occur. None of us want the cost, liability, quality experience. And the managed care plans are listening to that and saying, okay, we now have objective data. We will give you extended stay. We have multiple hundreds of examples of that happening.
Mhm.
If we look at the assisted and independent living, the equation changes a bit because it's much more of like a kind of tenant landlord relationship. Those
Mhm.
owner operators, they want to have obviously a great experience and they want their apartments full.
Yeah.
So when somebody comes in, it's a great part of the way we welcome you to our facility is to just get some baseline measures. So take a quick walk, do this or this. Here's your baseline looks really good.
Mhm.
We would love you to have this on your own phone. Great. Now the resident has it on their phone, they can measure and monitor. If at that time we're able to detect that, your fall risk is kind of here or your mobility, there's some concerns, let's make sure you get into the fitness center or let's come in and work with our therapy team.
Mhm.
And same sort of thing in the assisted living. We are helping those owners and operators with occupancy because if we can identify the problem before the event occurs, we help them stay age in place, which is all what
Yeah.
everybody wants to do based upon this important mobility intelligence signal. So I'll pause there. We could keep talking about workflows, but hopefully that gives you a sense for what the deployment looks like.
Yeah, it's very interesting. It sounds like you guys are really cultivating a shift from reactive management to proactive management when it comes to,
Amen.
mobility issues, right?
Yeah, you
Because
got
it's
it.
like you don't want to wait for that first fall to get somebody into physical therapy. I mean, that's one of the big things. I'm sure I know you're aware. It sucks that as clinicians, we can really only see people once they've already had the adverse event, once they really need a lot of care. And a lot of times it's tough to try to bring us back from that state of needing a bunch of care and then create forward progress. And so there's a huge benefit to having the objective data to show, hey, we need this beforehand. We know that this is going to lead to an adverse event. If we catch it beforehand, we don't even have to deal with that later on down the road.
Right. And you're spot on. And one of the challenges that I think I'll just be sort of we in healthcare tend to wrestle with is we say, well, nobody pays for prevention.
Hmm.
But I'll challenge that assumption to say, actually, yes, we can, but we might need to change the way that we're framing paying.
Yeah.
So let's go back to the assisted and independent living. If we're able to, with proactive outreach, help identify the fall before the fall occurs
Hmm.
and help keep Mrs. Jones in her independent living, the owner operator, in this case, the landlord, experiences economic value. Their room is rented. I'm being a bit cold on this,
Yeah.
but I think it's an important shift that we need to think about. We just added meaningful value. The therapy team or the fitness team just was paid for prevention. And
Hmm.
we operated at the top of our license by saying, we understand the rising risk. Let's get out and address this now. It happens every day in sports medicine, right? We can do ACL injury prevention programs. We can do all these other things. We can strengthen and condition. Same thing applies here. We're just giving the signal and maybe the permission, if you will, to say this is the reason why. So we were
Yeah.
just paid to move upstream. Same thing in the hospitals. What if we can identify that Mrs. Jones has not been moving or the quality of her mobility has declined since discharge? Let's proactively reach out and prevent that 10% increase in readmission. which
Yeah.
is driving costs. So sometimes I think we unfortunately, look at our shoes a little bit too much because we do have the ability to move into the pay for prevention. It just may be that we need to reframe how we think about that.
And I love that viewpoint because I'm not one that personally ascribes to kind of the pessimistic worldview of, oh, like we'd love to do all these things, but that'll never get paid for, so it'll never happen, or we can never implement that. I think most people acknowledge the capacity for synergy in systems where if you do things the right way, I think everybody wins and it kind of elevates each party, right? The people that need to get paid, the people that need to get treated, and the people who need work, right, get the right work and they get satisfaction from that. So it's like if we can create the right system that kind of elevates everybody as a whole, I think everybody wins out of that. And I think that's a more optimistic worldview. And it sounds like One Step's kind of creating that data mesh layer that allows us to elevate the whole system so that everybody wins.
Yeah, you're right. And it's hard work
Yep.
because if we go back to, say, the customer discovery conversation, what keeps you up at night? My margins, I just keep getting margin compression.
Hmm.
I have to pay inflation. I have my wages for my team needs to come up. I've got high staffing turnover. My liability costs continue to go up. Again, trivia for the day that for the owner operator, those in the senior living space, the two largest drivers of liability claims in senior living are falls and acquired wounds,
Hmm.
the bed
Yeah.
sores.
Yeah.
And the average settlement, I was on a podcast not too long ago with a liability carrier. The average settlement is something like $260,000.
Wow.
Those are like the real discovery problems.
Hmm.
Now, back to your point, I share your worldview as the eternal optimist, but also the realist. Whatever solution we bring to the market, and we were chatting a little bit about this before we jumped on, we like to frame it up in three ways. It's the CEO model.
Hmm.
We need to bring clinical value that's assumed.
Hmm.
We validated that. We've got data. We're showing that it actually works. There has to be economic data or value. And that may be an additional code, but how may we support somebody in a value-based care payment model? How can we support an ACO? How can we support the tenant landlord relationship? How can we support extending the number of days in a skilled nursing facility? How can we support the owner operator by working with the liability carriers to say, hey, if you use these kinds of technologies, the brokers will be able to go back to the underwriters and say, this facility is doing well, give us a lower rate. That's a
Hmm.
conversation we're very deep in right now. And then there has to be the O of the CEO is the operating value.
Mm.
By operations, am I saving my team time? And it may be you have to really understand the time. So, gosh, it might have taken an extra 30 seconds to take the phone and take a walk. But what time did that save if you reduced, 2 out of 10 falls? Each fall requires, I've heard different numbers, anywhere between like 5 and 10 hours of team time.
Oh, wow.
So think of the impact there. And then, do the technologies integrate into their source of truth, which is their EMR? Are they simple to use? Are they intuitive? Is the data not just data for noise sake, but is it data that's truly insightful and actionable? I think if we, with good discovery and that sort of a framing of clinical value, economic value, operating value, that's where we have the opportunity to intervene and start to move into the yes, we can bring value to prevention.
Mhm. And, you've talked a lot, almost like theoretically, of like, here's all the things that we could do. Can you give me some of the big wins that you've had in approaching either senior living communities or even in some of the other verticals that you guys have operated in? What have you seen as far as results when you implement One Step?
Yeah. So all of what I'm describing is not just theoretical or vaporware. We're doing
Mhm.
it today. This
Yeah.
is this is
I know
this
you
is
have the
real.
data. Yeah.
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 Yeah, this is real. So if we look
I'm
at,
just
let's
curious
see,
about like, what are those big wins that you've been experiencing?
yeah, so senior living, again, we talked about falls, right?
Mm-hmm.
It's the when and it's the how many. Over a several year period
Mm-hmm.
in many hundreds of facilities to see a sustained reduction in falls in that 23 to 25% is fantastic.
Oh yeah.
That we could almost do, there's the mic drop, right? I mean,
Yeah.
that's for
That's
for all
enough.
the
It's a
reasons that we know
podcast.
that's,
Yeah.
yeah, yes, that's right. So that's tremendous. Being able to help these owner operators that are feeling the squeeze from our managed care partners
Mhm.
to shorten length of stay. And we see all of the struggles that the managed care plans are having today to equip them with objective data that allows them to have additional days is real,
Mhm.
because it's not only the per diem payment that's good, that more than covers the cost of a one-step deployment. It's one extension of care of 5 to 7 days it's a 4x return easily. That's on one resident with one extension in a community. But then think of the impact on falls coming down, lowering the liability risk. That's a
Mhm.
win. Think of the impact on fewer hospitalizations. What does that do on quality? What does it do on stars ratings? What does it do on the total cost of care? And if they're in a value-based payment model, on their true up the following year.
Mhm.
So those are all real. The owner occupancy, I don't have hard data on that yet, but I can tell you anecdotally, it's happening. We
Yeah.
know we're helping people stay in their preferred place of residence longer, which is good for everybody. That's all on the front end side. We haven't even talked about the billing opportunities. So our therapy teams, physician teams are using OneStep to bill for gait training in the clinic. It's a code that is available that we tend to
Yeah.
not to use a whole lot of. We can use OneStep for the physical test and performance measures, which one of the challenges has been always been, I need an object, I need a report. Well, we
Mhm.
give the report instantaneously. So there's some additional CPT codes. And because we run in the background and passively, we have so many partners that are using OneStep very successfully to bill for remote therapeutic monitoring.
Oh,
Any number of examples of that on our website of the economic value that we're bringing to our partners. So if we go back to like, what problems do we solve for? We like to say we're the vital sign that crosses over that entire continuum of care.
yeah.
Skilled, AL, IL, home care, outpatient, whatever it is, part A, part B, we're a solution that solves a lot of the real problems that we hear every day. That's where I think we get really proud of the work we're doing, and we're so grateful for our partners who continue to design and be creative with us.
And because that vital sign is so broad, have there been any big wins that have surprised you? So say you intended, one step to be implemented and you knew you'd reduce falls, you knew you'd improve occupancy, improve operator efficiency, but was there anything that came out of it that you went like, "Oh, people are really liking one step for XYZ and we didn't anticipate that."
Yeah, there's probably 1,000 of those. Mm,
Okay.
yeah.
Need another hour then.
Yeah, yeah,
Yeah.
we will. But as I mentioned, we're so grateful for our partners who have said, "Hey, I bet this works here. I bet
Mhm.
it works here." So I think one of them with one of our large health systems. So we launched university academic based health system. The initial launch with them was in their outpatient physical therapy and occupational therapy with, fairly traditional musculoskeletal neuro rehab population.
Mhm.
When we told them that, well, yes, you can do a 6-minute walk test with OneStep, the cardiac rehab team said, we need this,
Mhm.
because that's the gold standard in cardiology is 6-minute walk.
Mhm.
And the challenge has been there's not that many cardiac rehab centers available.
Yeah.
So it's a real challenge. How do you get in your 24 visits post cabbage or MI or whatever it is? Well, now we could enable good cardiac rehab to be done virtually using the same gold standard measure. Just yesterday, we had a conversation with a leading heart failure physician for a very, very large academic health system who said, this is very interesting. We've got some work to do to really move into to make this actionable for the cardiology space. But he said, you are 100% on the right track.
Mhm.
Same thing with, I mentioned earlier that a COPD group, large health system that said, help us power the COPD program. Nowhere near on our radar screen. Normal pressure hydrocephalus
Oh,
came to
wow.
us
Yeah.
without really intention. Oncology came to us without intention. So again, our good news is we can go everywhere from a young company. We like to say
Yeah.
we're past the startup phase. We're about 7 years old and commercialized for about 4 years now. It's nice when you can go everywhere, but if you go everywhere, you don't go anywhere. So that's where we've had to keep the focus, where we see the new use case. Great, let's go validate that. And once we've got validation and we understand it, now it's an expansion opportunity for us.
I want to touch back on the accessibility element of One Step
Mhm.
because I think that's something we haven't touched on enough today. That's something that I'm very passionate about. Is I think a lot of people don't realize, like, even if you have a solution, we can say that One Step meets and exceeds the standard of care. But some people might say, well, why not fix it if it ain't broke, even if it is broken. But a lot of people just go to your physical therapist to get this gait analysis done. Have a licensed provider conduct this. But a lot of people just don't have access to that. There's a lot of communities that like you said, they can't go to their cardiac rehab. How has One Step been able to impact access to care in these rural communities or these underserved populations?
Yeah. So I give a couple of examples. One of our large academic health system partners said, let's launch initially with you around our total joint. So pre-surgically, most elective hips and knees participate in a joint class. Here's what's to expect. Here's the exercises, all those sorts of things. Well, now they're doing those virtually. And now, as part of the way, you come into our practice, we want to get baseline measures. How are you functioning pre-surgically? Have your procedure. Now we're moving post-surgically. We can see how you're moving. And you know what, Daniel, you're doing great. You are right on track. Continue to stay in touch with you using One Step virtually.
Mhm.
Here's your home exercise program. As I mentioned, we know what recovery should look like. You're doing just fine. You don't need to come in 3 days a week or whatever that schedule might be.
As single mom, that could be a
Or
big
yeah,
burden.
or if you got to drive 30 miles
Yeah.
to get somewhere. So we've known that virtual care has worked, but we've been limited oftentimes to what the patient is telling us or asking the patient to do something with high friction, like sit in front of a camera. We know that there's a cool factor, but we see adherence drop off at about 12 days for those kinds of programs. So now to be able to use what they already have and to use it passively, we find that our partners' patients are choosing to engage with their own data 6.05 times a week.
Oh,
So
wow.
very high levels of engagement because
Yeah.
it's real-time feedback. So Daniel, you're doing great with your total knee. In fact, you can see your own objective data
Yeah.
and you say, way to go. My exercises are working. I'm going to keep going. So what that just did was made life easier for you. It eliminated the copay for that visit and it gave me, your provider, a free spot. I have space on my calendar or my schedule to get in a, higher need or a higher priority patient. But if I also see you're going in the wrong direction, you
Bring it
can
back.
message me and say, something's not right. Or I can say, wow, I see that things are moving in the wrong direction. Let's get you back in here. So
Yeah.
very back to very proactive and efficient care. And we have several partners that are applying for funding in the Rural Health Transformation Program.
Mm.
And they're including One Step in their application because, now they have objective data about mobility that they've never had before.
Yeah.
And I'll give you one other just bit of trivia. I was at the CES in January and was
Yeah.
at some of the digital health panels. And there was this panel with companies that you would all know around digital health, very
Mhm.
impressive. And one of the companies does home sleep studies. And they said, so based on our 30 million home sleep studies, what we've learned is that when the patient and their provider see the same objective data, not subjective, objective
Yeah.
data, adherence to their prescribed program goes to 87%.
Oh, wow.
Yeah. So again, that's where back to like the rural health and access, we're giving the patient, the provider, the same data, which is part of the reason I think we see high levels of engagement and sustained engagement, and
Yeah.
frankly, positive outcomes.
I always use the example of like a weight scale, right? Like if you're trying to lose weight and it's really difficult, you're sticking to this diet, you're sticking to this exercise program, but you don't have any way to actually see if you're losing weight, right? After about 2 to 3 weeks, it becomes really easy to say, am I really getting what I need out of this and kind of drop off the program, right? But if you can see that number going down every week and kind of make the invisible progress visible, then you can improve adherence to that program. And it sounds like that's exactly what One Step is doing. I really like that element of the provider and the patient seeing the same data because I think one of the biggest predictors of whether or not somebody sticks to and achieves an exercise program or any medical intervention is really that provider patient relationship, right? Can they
Mm.
trust one another? And having that same objective link between them to say, hey, what my provider is seeing is what I'm seeing. I'm on board with it. They're on board with it. We're on the same team tackling this problem together. I could totally see how that would drive adherence and make outcomes so much better.
Right. It's a really good point about the scale. I'll take it, no pun intended, one step further.
Uh-huh.
So
I bet you get a ton of puns with one
uh,
step.
we do, yeah, yeah. But think of the power of not only seeing your mobility improve, but being able to tie that back to the activity that drove it.
Mhm.
So, wow, since you've been on this medication, look at what has changed.
Yeah.
Since you've been using this prosthetic or this device or this implant, look at what has changed. Since you've been doing your exercises, look at what has changed. So it's not only seeing the progress, but it's giving you an understanding of what drove the progress.
Mhm.
That's been the missing element, in my opinion, around sustained engagement. You've
Yeah.
experienced this as a PT. How's your shoulder feeling? Better.
Yeah.
Well, why? I don't know. It seems like the exercises are working. Well, imagine, okay, when you started doing this exercise, look how much your stability improved. Look how much
Yeah.
your fall risk came down. There's such power there and such positive feed forward that drives engagement, not only to the patient, but to the provider. And we can speak to it. It's hard when a
Yeah.
patient comes to us and says, I'm not feeling better. It hits you right here
Yeah.
versus, oh, I know when we did this, this was the true impact. Cool. We're on the right track. We should do more of that.
Yeah, like you said, tough as the provider to say, like, sometimes you're giving interventions and you kinda go, "I know the data says this intervention should work, but is this working for this patient?" Right? If you don't have the
Yeah.
right objective data, sometimes you're just kind of guessing based off of, what would be large population norms that you can get in a research paper or something like that. And that kind of drives us into the last thing I wanna talk about before we run out of time is how do you feel that having this big data set, right? The data set that's much larger than you could ever get with a scientific study,
Right.
data set that is based in the real world, like from people actually moving in their home environments. How have you guys been able to drive new insights from that? And if so, in what areas? Like, have
Yeah.
you challenged any common beliefs, right? If somebody said, "Oh, well, we believe this gait metric drives falls in this population, but actually it doesn't. It's more so this one."
We've confirmed a lot of beliefs.
Okay.
What I
Yeah.
referenced earlier about the hip and knee replacements and, the actual recovery being much more
Yeah.
prolonged than or passively than what happens real world versus what happens actively. We've looked at data related to obesity and GLP-1s.
Mm.
With GLP-1s, we know a lot of the weight loss is due to muscle mass loss, sarcopenia. And again, there's strong data or evidence that says muscle mass and sarcopenia are related to gait changes.
Mhm.
So we've been able to show the relationship between BMI and gait parameters.
Mm.
That's really interesting. So we've got some fairly interesting conversations underway there from a commercial
Yeah.
perspective. Nothing urgent, but some interesting ones. We've been able to look at, because we have partnerships with neuromodulation companies that are using implantable stimulation for pain relief. It's intuitive. If you hurt, you tend to move differently. Well, now we've actually been able to demonstrate that taking like an Oswestry disability index, kind of the gold standard for, say, low back pain, and correlate that to mobility. And as you would expect, there's a very strong relationship between what a patient says they feel and what is actually happening.
Yeah.
So closing the gap between subjective and objective. Some really interesting data is very early for us since we're integrated in so many EMRs, we can begin looking at EMR data, comorbidities, mobility, and how those start to tie into things like falls and other performance. And then maybe one last one that's was very interesting to me is in the Parkinson's disease space. I think we now feel pretty comfortable saying this is what a Parkinsonian gait looks like
Yeah.
from through the lens of
Yeah.
one step. And now we can look at over the course of a day, what happens with
Yeah.
mobility. So as you'd expect, much more activity earlier in the day, less fatigue, a bit more fresh. And then as the day moves on, there's less activity. So time through the day and now quality of mobility during the day. And to be able to see that gait actually becomes more symmetrical as the day goes on,
Mm,
which is associated with the shuffling gait.
yeah.
So very interesting. One of the things that would be great to solve for, it's really tricky, but is the thing that the providers that are treating people with Parkinson's disease is, well, your gait freeze is becoming better with the medication. It's really hard to measure that.
Yeah.
And so we today can pick up when somebody stops. The challenge is, can you understand, is it because it was a freeze or did the person walking just choose to
Oh,
stop?
yeah. Mhm.
So I'm just use those as examples. And then again, cardiology, I think we'll have some really interesting data coming from that as well. So there's so many exciting things for us to be able to look at. What drop? Prosthetic use. We've got many, many thousands of patients with limb loss that we've been able to measure and monitor. And you could start to see the impact of a particular brace or a particular component to a prosthetic. So there's awful lot of data there. As a data geek, you could just get lost in all of that. And we need to
Yeah.
continue to balance let's look for cool trends, but let's also make sure that we understand the commercial value and frankly the value back to our partners that we're serving.
And on that note, I mean, how do you see clinical practice and clinical research in general changing in response to all these really cool technologies like OneStep, being able to access all this passive data that is just being captured all the time? Like with OneStep, it's not like you guys invented phones capturing motion data. That was just
Right.
existing and you harnessed it. The same thing, I mean, everybody's wearing all these advanced biometric sensors on their wrist with,
Yep.
Apple Watches and smartwatches. We're getting so much passive data in, and as companies like yours capture it and harness it, how do you think that's gonna change the field?
It's so rapidly changing the discussion. 2 hours ago, we were on with Elegant Company that has technology that can treat vestibular problems.
Mhm.
And as they move into their final pivotal research projects, they need passive data. So it was interesting speaking with them. They said, we love what you're doing at One Step. Very likely we'll want to work together, but we're talking with some other solutions because, to your point, there are a lot of ways to get data. The questions will be, is your data validated?
Mhm.
So we feel really confident, being able to say, yes, we started with that as an operating principle. And then are you validated against a particular population? And because we have so many of those populations in our database, we can start to create that normative value pretty quickly for them. So it's a really exciting space for all of us. The challenge, I think, is sometimes from the research side, which tool am I going to use? Which tool am I aware of because things are moving so quickly? And then how is that data helping to support whatever I'm trying to demonstrate in my research projects? So, I could kind of ask the same question, like, how has the expansion of machine learning and large language models and AI
Mhm.
accelerated the
Yeah.
ability to do research? An exponential improvement. And now to be able to get real world data, it's very exciting. And the good news is it ultimately can accelerate the time from bench to bedside.
Yeah. We're at a really exciting kind of like confluence of events where we have increasing amounts of sensors just in daily life that are capturing more data, increasing amounts or technology solutions to harness that data, and then better processing power to actually go through all those data and pick up trends. It's an exciting time to be in healthcare and in healthcare
Yeah.
research. Able to do things that we never have before. And, with that, you've touched on this a bit of where One Step is going, over the next 5 or so years. Do you guys think that you guys will just lean into expanding the beautiful simplicity of what you have with One Step, or are you looking into other approaches to capture gait metrics, or where do you see the company going in the next few years?
Yes.
Yes,
Um,
all of it.
yeah, certainly our core is this,
Mhm.
right? And continuing to find opportunities to add value to this whole crazy healthcare ecosystem. Again, whether it's the device companies, the risk-bearing entities, the health systems, the senior living, the provider community at large, we'll continue to keep working there and expand the use cases, but being guided by the idea that, again, the CEO framework. It's got to be clinically validated. It's got to deliver economic value. And it's got to be operationally sound. And then, do we start looking at other opportunities and ways to capture data? Sure. You always have to have that level of innovation in your organization. And how do we continue to create improved access?
Hmm.
So it's not only access to the tool, but access to the patient, access to the provider, access to whoever in the ecosystem is going to meaningfully interact with this information. So we'll continue to expand, but I'd say we're so thrilled with the impact we've been able to bring to our partners
Hmm.
to help them improve care, improve their economics, improve their operations, that we feel really good about what we're doing. We can put our heads in the pillow at night and say we've helped people. And now how do we continue on with that mission by making the product that much better and improving access even more?
And it sounds like you guys are suffering from the great problem of really just having too many avenues that would be really fruitful to explore, rather than too little. Like you guys aren't stretching to find an area that one step work.
Right.
Yeah.
Right. We're doing the work to stay disciplined as well.
Mhm.
Mm.
Yeah.
We purposefully will make some bets. Let's go try this and let's learn as quickly as we can. Is there value here? Are we able to deliver real value? And then do our customers find value? And if the answer to those is yes, good, let's do it. And if we learn quickly that it's a yes, but not today, great. It
Mhm.
doesn't mean it's a never. It just would mean let's stay disciplined as an organization. Let's keep our focus because, and we've got so many listeners here, it's when we lose focus is when bad things happen to
Yeah.
organizations.
Well, I trust that you guys will stay disciplined, that you guys will really be tackling all the areas that we've talked about so far. I mean, there's just so much potential for One Step, so I'm super excited to see where you guys go, over the next few years. But I've already kept you a long time on this podcast, so
Such a
I
fun
think that's.
conversation, though, Daniel.
I know. Maybe we need to have another one sometime soon.
Let's do it.
But thank you a lot, Pat, for coming out and sharing with the folks what you guys are doing at One Step. I know that One Step and you personally will be at the Post Acute Care and Senior Living Workshop on May 27th in Louisville. Is that correct?
Can't wait. Yeah, that's right.
Yep. So if anybody out there listening is interested in what Pat is talking about or what One Step is doing, be sure to follow up with them there. And then, Pat, where else can the folks keep up with you or One Step?
Yeah, for sure. And just a plug for the AgeTech, if you have not been to an AgeTech Connect meeting, go. They're great. It's a wonderful crowd, and they are all about networking and meeting people and having very safe conversations like, hey, I heard about you or tell me what you do. So feel very comfortable going into those meetings. So it's a huge plug and a kudos to what you and the team have built there. Yeah, so from OneStep, go to our website, pretty simple, onestep.co, not com, onestep.co. You can follow me on LinkedIn, where I've actually been chronicling my recovery from a hip replacement 4 weeks ago
Yes.
with OneStep has
I've
been
been keeping up with
tracking
that.
nearly every step. So lots of information on my LinkedIn page. And if you want to email me, it's just pat@onestep.co. Would love to engage in conversation about what we're talking about at OneStep or any other myriad of topics that came up in this conversation.
Well, perfect. Thanks again, Pat. Look forward to our next conversation.
All right, Daniel, thanks so much.